Um, a very good evening to all the pediatric hematology from India who have joined. And yes, a very good morning to you both, Dr. Tim and Dr. Eric. Till now, we have had a series of webinar which actually focused on improving survival and outcomes. And also, we did have a couple on pharmacokinetics and dynamics too. So this one would is particularly focused on what happens after that. So not just the EFS and OS are important, and OS with a good quality of life is as important, and actually takes a hot seat now and is in the limelight since we have attained excellent cure rates with the contemporary protocols. And today we have two eminent speakers and two pediatric oncologists actually who is more focused in cancer survivorship and also on late effects of therapies. We have Dr. Tim. Both of them work at Seattle Children's Hospital, and Dr. Tim has had a recent publication also on ototoxicity and prevention of cisplatin-induced hearing loss. He also does research in health services delivery. And our second speaker is Dr. Eric. He also has a special interest and focusing on cardiotoxicity and prevention of cardiotoxicity in cancer treatment. As all of you know, some anthracycline is, if you want to say it, it is like the backbone of treatment of especially pediatric solid tumors. And this is something, both ototoxicity and cardiotoxicity is something that we frequently encounter, and they are to shed light upon the latest trends and how and what and where to do. So I think without much ado, I would like to welcome both Dr. Tim and Dr. Eric Chaw to this session. And we will have these two sessions, 20 minutes each. And at the end of it, we can take the discussions. All of you can type in your queries in the chat box, and we'll take questions at the end of both the sessions. So over to you, Dr. Tim.
All right, Dr. Madeira, thank you very much for the kind introduction. And I apologize to everyone. My voice is a little bit hoarse. I'm getting over an illness that I had last week. But nonetheless, I'm really excited to be here and talk a little bit, not just about, the progress that we've made over the last several decades in curing children with cancer, but thinking about progress that is being made and hopefully will continue to be made in allowing those children to grow up and live their healthiest lives. So, unlike my colleague Dr. Chow, who is an international expert in cancer survivorship and cardiotoxicity, I don't have quite as much gray hair, but I am nonetheless excited to talk about hearing loss, ototoxicity. On one hand, consensus areas that we really have learned a lot in the past decade, and then some controversy as well, which I think is always exciting, and hopefully future directions to take us to improved care. So that is a little bit of what my outline is going to be. First, we're going to talk a little bit about cisplatin-induced hearing loss, how it occurs, why it matters. We're going to focus a bit on two large randomized controlled trials that really set the stage for where we are today in terms of our standards of care regarding otoprotection. And then finally, we'll take a little bit of an eye towards the future and think kind of beyond the current standard of care and look into an area of and answers. So first, cisplatin is thought of as kind of the biggest player in ototoxicity in chemotherapy in pediatric oncology. And of course, this is a commonly used medication in a lot of protocols, especially for a number of solid tumors, not only in adults with cancer, but also children and adolescents. Now, the final common pathway in cisplatin-induced hearing loss, I've circled here, and that is through the destruction of the outer hair cells in the cochlea. And the cochlea in your ear is a really metabolically active organ, and therefore quite sensitive to reactive oxygen species or oxidative stress. And platinum agents can infiltrate these hair cells and cause, reactive oxidative DNA damage that is permanent and irreversible. Now, in terms of how platinum agents get into the outer hair cells, I think most commonly hypothesized pathway is via the stria vascularis through the endolymph. Although there are folks that have hypothesized other alternative pathways, such as direct access through the perilymph via the blood vessels as well. Regardless, I think it's important just to appreciate that when cisplatin penetrates outer hair cells in these cochlear structures, it can really remain there indefinitely, meaning that ototoxicity can be right after exposure, but sometimes may also be delayed. Now, the burden of ototoxicity, I think, has been coming to more children survive their cancer and treatment. Up to 60% of all comers in pediatric oncology who are cisplatin exposed will go on to develop long-term ototoxicity. Again, this is irreversible, and because of this, can have lifelong effects on children's speech and communication, their development, their neurocognition as they age. Because of all of these things, it can influence their end outcomes in terms of social functioning as an adult, their employment, their income, and also their quality of life. Although there are interventions like hearing aids for some folks, depending on the degree of hearing loss, these still come with challenges and effects that can influence people long term. This is especially important in certain disease groups where cisplatin exposure is really high. Among certain subsets of pediatric patients, up to even 70, 80, almost 90% of patients can have some degree of significant hearing loss. Because of this is something that is really important in survivorship, not only to clinicians, but to patients and families. And I think a priority area for the development of interventions. So when it came to the early development of otoprotectants, just given how metabolically active the cochlea is and how sensitive it is to reactive oxygen species, there were a lot of natural agents that were developed and chosen to think about that would reduce reactive oxygen stress. In addition, general inflammation was also kind of a rational target. So all of these agents, starting with sodium thiosulfate and acetylcysteine, which have been some of the more frequently tested agents, as well as dexamethasone below, were some of the first things that made it into testing. So it works by ameliorating oxidative stress in the cochlea, and it does so by forming inactivated complexes with cisplatin. Because of this, I think there's potential not only for the prevention of off-target effects like ototoxicity, there's also potential for impacts on-target effects, including the efficacy of chemotherapeutic agents. So because of this, sodium thiosulfate is administered 6 hours after cisplatin to avoid any potential interference with peak anti-tumor activity. Now, there were 2 trials that tested sodium thiosulfate in a randomized controlled fashion among pediatric patients with cancer, with the primary endpoint of assessing whether ototoxicity was reduced. And the first one that I think is simpler to speak about was SIOPEL 6, run over in Europe. And this was a randomized trial of 109 children, all with standard risk hepatoblastoma, who were treated with interval compressed cisplatin of 6 cycles, and then were randomized um, 1 to 1 to receive cisplatin alone or cisplatin platin plus STS. And from an ototoxicity standpoint, this intervention was a really resounding success. The incidence of cisplatin of ototoxicity that was quote unquote kind of clinically significant based on a hearing criterion called the Brock criterion was half that of patients who were receiving standard of care only. Still, I think it's important to note that 33% of these patients on the intervention arm still developed clinically significant hearing loss, but the reduction was very impressive. On the right, I've shown the Kaplan-Meier curve of event-free survival. The overall survival curve looks pretty much exactly the same between the two randomized arms, showing that there was no difference in relapse risk or overall survival, again, not shown between the two arms, suggesting that STS did not change cisplatin's anti-tumor effect. On top of this, the toxicity profile in SIOPEL-6 was overall quite favorable. There was no difference in infectious complications. Though sodium thiosulfate is fairly metagenic, there was no difference in severe nausea when given alongside cisplatin. There was one patient with an attributable toxicity of metabolic acidosis that required them to come off of the intervention arm. There was also one child that dropped out on the intervention arm due to grade 2 nausea that the family had a preference to remove from protocol therapy. Of course, that patient did develop hearing loss with subsequent cisplatin cycles. The other trial conducted in the US was ACCL 0431, and this was a little bit of a different big trial of a similar amount of children, 125. But the main difference in 0431 compared with SIOPEL-6 was that it enrolled children with all types of cancers that were treated with cisplatin. This included patients with hepatoblastoma, but also children with neuroblastoma, osteosarcoma, certain brain tumors, and some other rare tumors. This included not only patients with localized disease, but also metastatic disease. So it was kind of a study across all comers of cisplatin-exposed pediatric patients. When it came to the effect of sodium thiosulfate on ototoxicity, we saw really similar results. The incidence of hearing loss, this time evaluated by the OSHA criteria, was about half that of the observation or control arm. Similarly, in follow-up with kind of more modernized hearing scales in a secondary analysis, the rates of ototoxicity, grades 2 plus in this case, compared very favorably in the intervention arm to observation. Now, on the other hand, this is where a little bit of the controversy might have started to creep in when the study team compared survival between the control group and the intervention group on ACCL 0431. While it was not a significant difference, there was perhaps a little bit of a trend in lower survival among the STS group compared with controls. And in an ad hoc analysis that the study team had not planned for, they separated those patients into subsets of those with localized tumors at presentation and those with metastatic tumors. And among the localized group, they saw similar results to SIOPEL-4, where event-free survival and overall survival were pretty much exactly the same between STS and observation cohorts. However, among the group of patients with metastatic tumors, there was a little bit of a difference where the patients who were enrolled in the sodium thiosulfate arm, shown in blue, had lower rates of event-free and overall survival. So, taking these two studies together, first, in terms of consensus, I think both studies showed unequivocally that sodium thiosulfate was very effective in reducing cisplatin-induced hearing loss. It was safe and well tolerated, with a very favorable toxicity profile when paired with cisplatin chemotherapy, as well as other agents. And among children with localized tumor, it didn't really seem to hinder um, overall survival outcomes. I think it is also important to note that sodium thiosulfate alone was not perfect. Did not completely eliminate hearing loss, even though it abrogated those effects quite significantly. And all of these results together led to both FDA as well as EMA, European Medical Agency approvals for STS for in 2022 and 2023. At the same time, there was some controversy, I think, due to the design of these studies that I think there was a concern that sodium thiosulfate could potentially hinder survival outcomes for children with metastatic tumors. Now, this statement, I think, has to come with a lot of caveats. First, 0431 was not really designed or powered for the ad hoc analysis of localized or metastatic disease. Um, and because it was not powered for that, because it was not planned, I think that adds a little bit of some uncertainty to the results. One of the big drawbacks to the 0431 study design was that patients weren't randomized and matched by tumor type, disease stage, or risk assignment. And there was not a ton of really granular data about other prognostic factors that could be confounders in this sort of analysis. Um, so when I think national panels of experts have looked at this data, there has absolutely been this concern about survival differences among children with metastatic disease. And I think many authors have felt pretty strongly sometimes that really the two arms of 0431 not being matched for tumor types or prognostic factors might have influenced these results, especially considering that looking back at these survival curves, this overall survival of over 80% among children with metastatic solid tumors seemed a little bit higher than what one would expect when comparing to historical controls. And this control arm survival, hopefully y'all can see my mouse, it was probably a little bit more in line with what the investigators would have expected in terms of outcomes. Still, again, FDA and EMA approvals were given only for patients with localized solid tumors. So that is our current standard of care in North America, where if somebody has localized solid tumor, like a localized hepatoblastoma, we absolutely pair it with sodium thiosulfate. Someone with a metastatic tumor, absolutely not. Someone with a tumor that's in between, that's probably metastatic, might be a little bit more of a gray area, but I will say typically our standard of care is not to give sodium thiosulfate in this setting either. And other agents that are not cisplatin, like 24-hour carboplatin infusions that we give during tandem transplants for high-risk neuroblastoma, sodium thiosulfate is also not an indication. All right. Well, what about some other agents? You know, clearly sodium thiosulfate has some benefits that have been able to been shown, while also clear drawbacks to indications and use. First, I think it is probably helpful to think a little bit about the two major types of delivery mechanisms in ototoxicity. First, like with sodium thiosulfate, there's the systemic uh, uh, mode of delivery, either through like oral medications or IV. Obviously, there are some um, real upsides to this approach. The ease of administration, uh, and potentially, therefore, that being a little bit more acceptable to families, I think is a big draw to a systemic approach. Also, the consistency and comparability to prior trial approaches, I think, is also a potential pro. On the flip side, As we've seen with sodium thiosulfate, one of the obvious cons and areas for concern is theoretical interference with any potential anti-cancer effects of cisplatin or other platinum agents. On the other hand, tympanic approaches potentially reduce that risk for systemic toxicity as well as interference with anti-cancer agents. It also allows for either randomization by ear or participant. Randomization by ear might allow patients, pretty much all patients, to derive some benefit from an otoprotectant agent if it's effective, compared with only half of participants in a traditional one-to-one randomized control trial. It also could potentially control a little bit more for host and environmental factors, as well as some of the heterogeneity and confounding pieces, such as those that affect 0431. On the flip side, intratympanic approaches are potentially less tolerated, especially in younger children. They tend to be more resource intensive, requiring specialists in otolaryngology, and also the coordination of multiple services, not only otolaryngologists, but sometimes anesthesiologists for sedation and other sorts of procedures. In terms of some potential alternate agents with some interesting preclinical or clinical data, that I think will make their way into a little bit more testing in coming years. First, N-acetylcysteine, also like STS, reduces reactive oxygen species. The clinical data has been a little bit mixed. Low doses of oral NAC were when tested in adults in a randomized trial were not effective versus placebo. The oral dose here was 600 milligrams daily compared to a very small randomized phase 1 study in children where IV administration of a much higher dose, 450 milligrams per kilogram, so almost like an order of like 10 times higher dose of NAC, was well tolerated and resulted in significant otoprotection, again, in a very, very small cohort. Some intratympanic approaches with NAC have also been trialed with generally pretty null results, but still the study in children conducted by Eton Orgel that was published in 2023 that I've listed the citation here, I think has made this an interesting agent for some future study. Dexamethasone is an agent that I've you know, come to learn a lot about through my work with the intratympanic study, which was a dexamethasone-based agent. Human studies have largely been in the intratympanic space to reduce all the side effects that we know to occur from dexamethasone. There has been some indication in guinea pigs and rabbits, especially at higher doses of dexamethasone, of otoprotection, although in human trials, the efficacy has generally been pretty null, including dexamethasone in longer-acting delivery mechanisms, such as what we recently published with David Fryer in Pediatric Blood and Cancer. Now, what we did find with a trial of intratympanic dexamethasone was that it was well tolerated overall with a very favorable toxicity profile and something that was feasible to do at U.S. academic pediatric centers. So could be a delivery mechanism for other agents or potentially other doses in the future. One agent that's a little bit unconventional that has been gaining traction in the last 5 years has been atorvastatin. While there haven't been any established trials in humans, there's been a lot of interest in statin agents from a retrospective study that demonstrated reduced hearing loss among patients who were adults, many of whom received statins, and adult patients who were receiving cisplatin who also were receiving statins had about a 50% odds or 0.5 odds of developing hearing loss without any changes in overall outcomes. Of course, this was a study that was largely confounded by indication and probably has significant selection considerations in the study population. But that difference, especially in a very well-tolerated medication, has made this an agent that I think a lot of people have been interested in learning a little bit more about. But so I think, with these agents, we still have more ongoing questions and answers. Honestly, even with sodium thiosulfate, we have more questions than answers. There's a current COG study, ACNS 2031, that's actually looking again at sodium thiosulfate among patients with average risk medulloblastoma to see if there are survival differences and ototoxicity differences, almost to recapitulate some of the results seen in ACCL 0431. As I've alluded to previously, other questions really surround, whether some of these alternative systemic agents can be successful, whether tympanic approaches can complement already established systemic administration of STS, and maybe one piece that, for the sake of time, I won't go into too much, the role of generic sodium thiosulfate versus the FDA-approved PEDMARK agent. All right, and with that, I will turn things over to Dr. Chow, and I look forward to some of the discussion at the end of the session.
Thanks, Dr. Tim. Yeah, we'll take the questions at the end of the session.
Sorry. So thank you for giving me this chance to speak as well. So we'll review quickly the current evidence for dexrazoxane as a cardioprotectant. So just same disclosure for many pediatric drugs. It's off-label use, and I'll talk a little bit more about that in a bit as well. So risk factors for early cardiovascular disease. As we know, there's a significant greater risk of major heart issues such as congestive heart failure, coronary artery disease, stroke, compared with general population, in this case, siblings. This is a landmark study from Kevin Effinger, published in New England Journal of Medicine almost 20 years ago, which really was a clarion call to highlight many of the long-term adverse effects that long-term survivors of childhood cancer experience. As we know, anthracycline dose is one of the major risk factors. This is a nice review article from Star Armenian that shows the dose response, and you can see that there's an inflection point here when someone reaches around 200, 250, where the risk of, in this case, heart failure or cardiomyopathy is significantly increased beyond that point. And then similarly, radiation is a major risk factor for multiple types of cardiovascular disease as well. This just highlights some of the dose distribution seen in different forms of radiation therapy, with the left side being more older conventional photon therapy, whereas more contemporary immune modulated radioactive therapy is shown to the right, where the dose distribution can be more refined, decreasing the amount of scatter to organs such as the heart, which may still be partly in the target field, but portions of it can therefore be avoided. Similar to Tim's talk with the various drugs, dexrazoxane has had an interesting history. It was originally designed actually as a chemotherapeutic agent with this name ICRF 187. And so if you look in the literature, if you Google or search for that term, you actually find some of the older articles from the 70s and 80s, where it was originally tested but found not to be very active against the malignancies that was tested against. However, it was noted at the time to have some reduction in anthracycline-mediated cardiotoxicity animal models. The drug itself is an EDTA-like bis-dialpyrazine, which decreases oxygen-free radicals via intracellular iron chelation, but as other iron chelators do not provide cardioprotection, The main mechanism is now thought to be competitive binding topoisomerase 2 beta. So topoisomerase 2 beta is targeted by doxorubicin. 2 alpha form is overexpressed in tumors. The 2 beta form, however, is expressed on mainly in cardiomyocytes. And there's a variety of nice review articles that have been published over the years that kind of describe this. So there's been clinical trial data for dexrazoxane heart failure risk for quite some time. This is a nice Cochrane review from 2011, which really shows that cumulatively there was nearly 0.2 or 80% reduction in heart failure risk across these studies. However, these studies are mostly adult breast cancer patients with only a very limited pediatric data, which are noted in red arrows. However, the overall strong signal does favor dexrazoxane reducing risk of heart failure. As a result, this has led to FDA usage indications, but mainly in women with metastatic breast cancer who have received cumulative doses of doxorubicin 300 milligrams per meter squared or greater, based on the prior data, which are mostly in breast cancer patients. The ASCO guidelines have been a little bit more liberal, focusing on all adult cancers, but not pediatric, with a recommendation that high-dose anthracyclines, again, here, doxorubicin greater than or equal to 250 milligrams per meter squared, could be considered for dexrazoxane usage. The European Medicines Agency has previously had a warning on the use of dexrazoxane in children based on concerns on inducing second cancers, and I'll talk about that a little bit later. But in 2017, it removed that indication and said that that's no longer valid. So dexrazoxane in pediatrics, at least, the prior data up to the last couple of years was mostly focused on the short and medium term. So Steve Lipschultz, who's a pediatric cardiologist, performed a landmark study again more than 20 years ago now, using data from the Dana-Farber high-risk ALL consortium, where he found that dexrazoxane plus doxorubicin significantly reduced the frequency or likelihood of troponin release in patients treated with those drugs compared to doxorubicin alone. And then in a follow-up study, Steve and collaborators, Barb Aslin and others in the pediatric oncology group found that among T-cell ALL and lymphoblastic lymphoma patients, dexrazoxane was associated with greater preservation of left ventricular function at 3 years. There's been non-randomized research data. This is from the COG AML study 1031, which found a lower risk of left ventricular dysfunction with hazard rates of 0.6 in those patients who were given dexrazoxane upfront compared to those who were not. And this is data from Kelly Getz from CHOP. So to answer some of these long-term unknowns, COG study ALT11C2 was started back in 2011, 2013, and our goal was really to look at the long-term 10-plus year outcomes associated with dexrazoxane. First, at the time, there were still significant safety concerns. This was before the EMA removed its contraindication, and so there were still significant concerns about relapse, mortality, and second cancers primarily. And then obviously we also wanted to look at the long-term cardiac outcomes. So for this study, we performed prospective clinical assessment using 2D echo, which was obtained at all sites, anthropometry, blood biomarkers, and then the echoes, echocardiograms in the laboratories were centrally processed and reviewed in blinded fashion. Just to highlight that this was really a team science effort where the Children's Oncology Group joined up with the Dana-Farber Cancer Institute ALL Consortium, and we had good representation among multiple subspecialties, including cardiology, of course, with Steve highlighted there, and then key leaders in pediatric oncology who led many of the randomized trials that we were looking to recruit patients back from. And then epidemiologists and other collaborators such as Richard Aplink and Smina Badia. I'll mention David Fryer, who's a longtime leader in the otoprotection space that was involved in much of the work that Tim Olson just described earlier this hour. So these were the studies, our legacy clinical trials that we were focused on. Most of them were all phase 3 trials that randomized patients upfront to receive dexrazoxane or not. And then there was one single arm osteosarcoma study that where all patients received dexrazoxane. And for that study, we recruited controls that were matched and treated similarly, but not receiving dexrazoxane from the same sites that recruited them. What's nice about these trials is that there's a really large range of doxorubicin doses that covers pretty much all the doses that we currently use, ranging anywhere from 100 milligrams per meter squared upwards of 600 milligrams per meter squared in the osteosarcoma group. And then dexrazoxane was given uniformly in all these trials as an IV bolus pre-doxorubicin on a 10-to-1 ratio. So first, looking at late relapse and mortality, we found with 15 years of follow-up that there was no difference, and that limited to the randomized trials, you can see that the hazard ratios for both relapse and mortality were null, meaning that there was no difference between the dexrazoxane exposed and non-dexrazoxane exposed group. And then addressing the issues of concerns about second cancer, dexrazoxane, because it was developed as a chemotherapeutic, is also a weak topoisomerase inhibitor. And the question is whether it enhances the leukemogenic effect, especially when given with other topoisomerase inhibitors such as etoposide, as well as doxorubicin itself. So this was the initial report from the Hodgkin's trials back published in 2007 that found, based on 10 events overall, 8 in the dexrazoxane arm and 2 in the non-dexrazoxane arm, that there was a borderline statistical difference between these two groups, which led to a lot of concern among the pediatric oncology community about the safety of using dexrazoxane in this setting. In updated data from both those trials, as well as the T-cell ALL trial 9404, with 15 years of follow-up, we found no significant difference for second cancer risk overall. You can see that there was and still is a slightly higher cumulative incidence, but that the non-dexrazoxane containing arm, or DRZ negative in red, also has increases over time, and that the difference narrows greatly as time passes. And so you can see the breakdowns here. When you look at mortality only, there were 12 versus 10 cases with a non-significant hazard ratio. If you look at all cases that we're aware of, there's a 20 versus 6 difference, and then restricted to AML, MDS only, given the concern specifically for secondary AML. There was slightly more cases seen in the dexrazoxane exposed group, with 9 cases versus 5 in the non-dexrazoxane exposed group, but again, a non-significant hazard ratio. And these results were similar if adjusted for topoisomerase inhibitor exposures, including etoposide and doxorubicin doses. Full details are in the articles cited, JCO 2015, and updated data from Cancer publication 2021. So for this prospective cardiac assessment, we ended up with 201 accrual patients across North America, including multiple sites in Canada. And you can see that we overall had 488 participants, potentially from participating sites, but we could not find 279 of these patients, as the average time between their diagnosis and when we approached them was more than 10 years. And we end up with a final analysis of 195 with 6 patients who were enrolled that were subsequently found to be either ineligible or did not complete full study assessments, partly due to COVID in some cases. So this is a breakdown of the two groups. You can see that they're well matched in terms of the numbers of dexrazoxane, non-dexrazoxane exposed patients. There was a slight difference in age at cancer diagnosis and current age, as highlighted there, but the radiation and doxorubicin doses were similar. And again, the mean follow-up time is 18 years since cancer diagnosis. So these were mostly, as you can see, all young adults at the time of their assessment, which also made it more challenging to track them down, especially in a pediatric oncology group setting. This table is a little bit busy, but the full details are in our publication, JCO in 2023. But you can see that univariate comparisons, that there were significant differences in indices with systolic function, mainly fractional shortening, with borderline differences in ejection fraction, and that there was overall less people with lower function in the dexrazoxane exposed group at 4% versus 13% in the non-dexrazoxane assigned group. There were some differences in global longitudinal strain, as well as natriuretic peptide as a measure of myocardial stress. We stratify analysis by sex and doxorubicin, higher versus lower doses with a 250 milligram per meter squared breakpoint. The differences in thickness dimension ratio, left ventricular systolic function, were primarily seen in women, less so than in men, but both sexes did have differences in natriuretic peptides, but dexrazoxane status, and that the differences in LV function and natriuretic peptides were mainly seen in the doxorubicin 250 or greater group. So these are the multivariable estimates that we adjusted for all the variables listed there: age, current age, doxorubicin dose, heart radiation, history of cardiomyopathy. And you can see that differences by dexrazoxane status, again, mostly favored dexrazoxane having greater preservation or higher systolic function, global longitudinal strain, and less myocardial stress as measured by natriuretic peptides. When you look at the odds ratio of having left ventricular function that's lower, and here it's defined as fractional shortening less than 30%, or ejection fraction less than 50%, or a history of cardiomyopathy on medications, you can see that overall there's a significantly decreased odds ratio. The point estimates are similar for males and females, but mostly seen in those who received higher doxorubicin doses. And the values are listed there specifically. And that the magnitude of this effect is nearly identical to those seen in the meta-analysis of adult breast cancer patients that we showed earlier, where the odds ratio there was a little bit under 0.2 as well. So what are the limitations to this research? Of course, we only looked at doxorubicin only. There may be different impact of dexrazoxane and other anthracyclines or anthraquinones. Non-randomized AML data, which featured patients receiving daunorubicin and mitoxantrone, that would suggest that dexrazoxane is effective. This is from the Kelly Getz article from 2020. There's, of course, an ongoing phase 3 COG AML study currently testing dexrazoxane against liposomal daunorubicin with cytarabine, which will also look at this in a prospective randomized fashion. We also have to think about potential bias with the 41% participation rate. Non-participants were more likely to be male, racial, ethnic minority participants, and less likely to have heart radiation exposed. However, we were able to do an analysis of participant characteristics and outcomes by sites with more than 50% and less than 50% participation, which did not reveal any major differences. And overall, our enrollment of a roughly 50-50 split of dexrazoxane status is also reassuring. In subsequent analysis I'll show next, we do have additional longitudinal data which incorporated archived echocardiographic data and echo reports from COG sites, which allowed us to describe outcomes in many more patients than those that we were able to assess prospectively. So here in this analysis that's going to be featured at ASCO in a couple weeks, as well as in our International Symposium on Late Complications of Childhood Cancer, also in June. We had data on nearly 900 patients from those trials with 2,300 echoes. This represented nearly 70%, which were either prospectively collected or archived echocardiograms from sites, which were all centrally remeasured. Plus, we also had about 31% of the data points being echocardiographic reports only from sites. For those, we abstracted the key parameters that were reported on the echo reports. And for that, we can find that with this larger data set, left ventricular fractional shortening Z-scores showed that dexrazoxane exposed patients still had greater preserved function over time. And here you can see at pretreatment, both groups are similar, with the dexrazoxane group in red and the no dexrazoxane group in blue. But starting at 2 to 5 years after therapy, you can see a decrement primarily in the dexrazoxane unexposed group in blue. Similar findings we have for ejection fraction on a subset of patients, and then changes in left ventricular geometry, both end diastolic and end systolic dimensions also showed less dilatation over time, which also become apparent 2 to 4 years from diagnosis and remain persistent at 10 or more years. So Aaron Mobley, one of our mentees, is going to present this in a couple weeks. So in conclusion, after mean follow-up of 18 years, dexrazoxane appears to be associated with better left ventricular function and lower myocardial stress. I will note that while the absolute differences in LV function between these groups was small, dexrazoxane was associated with a reduced risk of lower function in young adult cancer survivors. And as our data and those of other groups have shown, the risk of clinical cardiomyopathy in these young adults, average age of around 30, remains low, less than 5%, but is expected to increase with age and may, for some groups, exceed 10% by age 40, especially in the highly exposed groups, 250 milligrams per meter squared doxorubicin or greater. And that the protective association that we saw, at least with this amount of follow-up time, was primarily in those treated with higher doxorubicin doses. So this does align with this guideline that was released in 2022 before our paper came out. It was also subsequently summarized in a Cochrane review published in 2023 by the Pediatric International Late Effects Guideline Harmonization Group, where they consider dexrazoxane use for pediatric and AYA patients expected to receive doxorubicin 250 milligrams per meter squared or greater or equivalent. There are equivalency ratios for daunorubicin, mitoxantrone based on cardiotoxicity that we've published on, where these drugs appear not to be one-to-one isoequivalent in terms of cardiotoxicity with doxorubicin. So in our opinion, it's important to account for that when using those drugs. And so then the question is, for those getting lower doses, doxorubicin less than 250 milligrams per meter squared, should this be a patient-centered decision with the family and the providers, accounting for risk of disease progression or relapse? Well, I will say the pediatric cardiologists in our group are always concerned about lower dose patients because, again, our data only goes up to 18 years roughly, and we don't know whether patients exposed to very lower doses will still have issues manifesting at a later age. So with that, I'll end. I'll just say that cardioprotection is, of course, a primary prevention strategy, but there are other ones such as lower doses and alternative agents, and that we don't have time to talk about today, but there's obviously ongoing research to develop other strategies looking at secondary and tertiary prevention as well. So I'll stop there, and I think we still have 10 minutes for questions.
Thank you both, Dr. Eric and Dr. Tim. I think that was a very clear perspective on where we stand with respect to cardioprotection and ototoxicity and otoprotection and what next to do and how to move forward also. Though there are a lot of problems with respect to the logistics for both, regarding especially ototoxicity and STS in a country like India and dexrazoxane both, which are because it's not freely available here too. We'll come because we have a lot of questions there in the chat box. I think I'll not delay. I'll go straight to the questions. Regarding ototoxicity, Dr. Tim, what do you think? I mean, role of host factors like race, any genetic factors, and also the associated because some of them, as you said, now you have a trial in medulloblastoma, also cranial irradiation because of alteration in the permeability, vascular permeability. Does it increase cisplatin toxicities?
Yeah, really, really great questions. I'll start with the easier ones to answer. First, there has been no association with race or ethnicity and cisplatin-induced ototoxicity on either kind of retrospective cohort studies or the ACCL 0431 data. We actually looked at that. That was looked at recently, and there was not any difference in ototoxicity risk. There are genetic factors that have been implicated in terms of like cisplatin sensitivity, but that's really outside of my knowledge base, so I apologize. Probably can't answer that with a lot of detail beyond that. And then with regard to cranial radiation, cranial radiation in and of itself is a risk factor for ototoxicity. And we know through retrospective analyses that patients who are cisplatin exposed, who then among patients who are cisplatin exposed, having cranial radiation is a risk factor for a greater odds of ototoxicity. However, whether it's like kind of an additive or multiplicative relationship is something I'm not aware of whether we know.
Have they compared, this is Dr. Warrior, have they compared cisplatin in brain tumor to neuroblastoma patient? Because with brain tumor, the risk is neuroblastoma, hepatoblastima versus brain tumors.
Yeah, there have been analyses across different disease groups. It's a little bit hard to make apples to apples comparisons. Like, for example, high-risk neuroblastoma, where the rate of ototoxicity is really, really high, like 80 to 90% in some cohorts, is probably driven by not just the cisplatin exposure, but high-dose carboplatin exposure used in transplant, as well as the fact that, a lot of these patients also have skull calvarial lesions that also get irradiated and might have some cochlear exposure. So I don't know of anybody who's done kind of a direct analysis of like cranial radiation, no cranial radiation in an apples to apples like disease-based group comparison.
Yep. So, I mean, do you have, is there any impact of sodium thiosulfate, just like ototoxicity, on other toxicities, especially
Yeah,
nephrotoxicity for
like
systemic?
nephrotoxicity, I think is like a really interesting idea. And on both SIOPEL-6 and ACCL0431, that was a secondary endpoint. Interestingly, there was actually a higher rate of like electrolyte wasting on both of those studies in the STS group compared with the observation group. Although GFR and overall long-term kidney function was pretty much exactly the same. I think the other major toxicity that people were interested in looking at in both those randomized trials was hematologic toxicity, and rates of grade 3 cytopenias were pretty much exactly the same in both of those studies across the arms. I have seen, a couple of case reports, or not case reports, but there's been a lot of interest in N-acetylcysteine as maybe a nephrorenal protectant in the setting of cisplatin, but I think that data is really quite young and far from definitive.
I think one of the questions that's common to both auto and cardiotoxicity again is, I mean, is there any relation with the duration of infusion? Both the cisplat, if you give over 4 hours versus vis-a-vis 24 hours, and also for doxorubicin and anthracycline, if you're going to give it as a short infusion or an IV push, or are you going to go it as a 24-hour infusion? Because some of the protocols insist on a 24-hour, 48-hour infusion. Others we gave a slow IV push, and some have a 6-hour infusion. So, is there any difference with respect to, and has it like proven impact on the toxicities?
Yeah. So I'll say for ototoxicity, sodium thiosulfate is really approved for like cisplatin infusions up to 6 hours. So we don't use it for those longer infusions. So it's not an indication for that like 24-hour infusion. In the setting of like kind of the shorter end of that 6 hours and the longer end of 6 hours, on 0431, they did take a look at that, and there was no difference in ototoxicity risk based on the duration of cisplatin infusion within those confines. The bigger association with ototoxicity, I think, which makes sense, as we know, is the cumulative cisplatin exposure. But as far as we know, under 6 hours, the infusion duration itself does not seem to have a major impact on risk.
So, if I may ask for cardiotoxicity again, Dr. Eric, I mean, there's giving doxorubicin. So, in hepatoblastoma, we give it over as a long infusion. So, I mean, in that context, do we need to do cardioprotective with the dexrazoxane vis-a-vis in ALL, where you would give it as a slow IV, very short infusion, or an IV push? I mean, do you think it makes a difference when you're giving?
Yeah, I don't think there's any data for giving dexrazoxane as a slow infusion. So it's given as a push. So I'm not sure that one would attempt to do that outside of a research question for a prolonged doxorubicin infusion.
I also wanted to ask, I mean, giving doxorubicin, if you're giving prolonged infusion, I mean, does dexrazoxane in that context actually bring down significantly the cardio toxicity? I mean, does infusion of anthracyclines have an impact on cardiotoxicity?
Yeah, I don't think the data for the prolonged infusion in pediatrics is that well established. I mean, that's been looked at primarily supported by adult data, but in pediatrics, even though some groups will do it, it's not clear that it's led to measurable differences. But that said, the hepatoblastoma patient has not been an easy one to study because of limited numbers.
Also, we have a question like where you showed that the differences in LV functions are not that very great between dexrazoxane plus and minus. So, I mean, was there a difference in the clinical heart failures acute between the two groups?
Yeah, so there was a difference in at least our definition of more significant uh, decreased LV function, which we set as a definition of shortening fraction less than 30%, ejection fraction less than 50%. In that group, there was a difference of I think 13 versus 4%. That said, people who might have a shortening fraction of 28 or 27%, in some cases are still considered normal. So these are still, in some cases, people who are in the low normal or borderline, defined area who aren't going to have symptoms. I will say in the small number of people there was one patient who had a heart transplant and a few patients who actually were on medications. Those were all primarily in the non-desrazoxane exposed group. But those numbers were pretty small, just a few people.
But you, Dr. Warrior,
Yeah.
I just have a comment. What you said about infusion is very true. I thought in pediatrics we don't do any more acute push at all. We only give infusions. So you can ask them. We rarely use any more acute push. We will only give infusions. So that's a very good point.
Sure. Thanks, Dr. Raj. So there's a question in the chat box regarding is there any long-term follow-up studies available for the preservation of hearing following sodium thiosulfate treatment, the long-term hearing loss?
Yeah, really great, insightful question, especially given the fact that cisplatin can hang out for pretty indefinite periods of time. In the longer term follow-up studies of ACCL 0431, that hearing loss difference has continued to be similar. I don't know if the SIOPEL-6 group has published like follow-up long-term data, but their study follow-up, even when they did publish it, was already pretty far out.
There's a question, I mean, Dr. Chow, what do you think? Why do you think we don't see a difference in survival in childhood cancer survivors using dexrazoxane compared to when it is used in breast cancer survivors? And is there any data on the quality of life on the survivors on this group with who didn't get it?
Yeah, we did collect quality of life data on all the prospective participants. And so I guess we never published that. I think we looked at general quality of life as well as we used like a Minnesota heart failure questionnaire. When we had looked at, I don't think we actually ended up looking at the final data set. We had looked at it at a preliminary analysis when we maybe had about 100 participants total, and we didn't find much differences. Main reason for that, I think, is again, most of these patients, even in the non-desrazoxane exposed group, are doing well, are not different as far as symptomatic cardiac function. And so the likelihood of picking up differences with the heart failure specific quality of life questionnaire is going to be low because the number of people who actually have heart failure is very, very small. And similarly, general quality of life with, I can't remember if we used PROMIS or SF-36. I think we used SF-36. Most of these patients are, these are Hodgkin's and ALL patients who are still relatively young. And while we know that the burden of late effects goes up quite a bit for Hodgkin's patients, at the time that we assess these patients, they're still on average, in their late 20s or early 30s. So the quality of life, at least in our initial look, was reasonable in both groups. But I think based on that question, we certainly probably should look at it again and maybe publish it, even if we find no differences. As far as the other question for survival differences, I think that's also the same. I will say, I think in the meta-analysis or the Cochrane review of breast cancer patients, I don't think they actually see a difference in relapse or mortality between dexrazoxane exposure groups either, but they do see a difference in heart failure, both clinical and subclinical. I will say for pediatric patients, again, we think dexrazoxane can be useful because it appears to reduce it does appear to influence cardiac changes, but we have very low mortality from cardiac specific causes, at least as at this young age still. And so that's why we're not probably going to see a mortality difference, especially by cardiac deaths. We do know from observational cohort data, primarily like childhood cancer survivor study, some of the large Dutch cohorts, St. Jude Life, that many of these patients, if we follow them as they age into their 40s and 50s, we will start to see a significantly increased cardiac mortality burden. And so it's certainly possible that if we were able to reassess these patients in 10 years, that we might start to see more of a difference. But at least the time that we did this study, we did not.
Yeah, I think that puts a bit clarifies a bit more for us. For us, we see a lot of acute cardiotoxicity, which is clinical, and we have a lot of deaths from cardiotoxicity during the
Right.
course of treatment, soon after treatment, maybe within a year or two. A long-term cardiotoxicity, symptomatic cardiac failure, vis-a-vis the patients we have compared with are quite high, even on because we usually cap at around 300 mg per meter squared, yet we have a lot of cardiotoxicity, which is symptomatic. So I just wanted, so there are two questions I just wanted to ask. So where do you put genomics in this context? I mean, do you think we would be able to tease out some patients who would be at higher risk and maybe provide for them, because we do see a lot of non-relapse mortality due to anthracyclines, and also the in a country for us it's not easily available. Now, having you showed your data regarding the absolute reduction is not that much, but we do have clinical heart failure and also symptomatic heart failure. Also, we LV dysfunction we have quite high when compared to the West. So where do you recommend dexrazoxane for us? Like,
Yeah, I mean, I think the acute cardiotoxicity is probably a related but somewhat separate phenotype almost. Whether the genetic risk factors for that are similar or different, I think is not well understood. Most of the pharmacogenetic literature has mostly looked at late cardiotoxicity. I think as with most genetic epidemiology, it's been predominantly in Caucasian, Caucasian, i.e., white non-Hispanic populations. So how that extrapolates to other racial and ethnic groups is hard to say. St. Jude Life has published some data looking at people of African American ancestry and maybe find that there's some potentially different SNPs or polygenic risk scores that may be influential. I think I'll just say at this point, there's emerging data that there are differences based on genetics, but it doesn't quite feel ready that these are ready for like clinical application yet, especially in by US standards, racial ethnic minority groups, which tend to be underrepresented in that type of research.
How about nutritional selenium deficiency or etc.? How about nutritional deficiencies, selenium or other?
micronutrient deficiencies, would they contribute or add on to this?
Yeah, it's possible. I don't know. I don't have any data on that specific question. Yeah. I'll just add, I didn't really present this, but in the osteosarcoma group, which got up to 600 milligrams per meter squared, they're all treated with 450 to 600. We did do a linkage with the U.S. Solid organ transplantation registry, which captures all solid organ transplants, so include heart transplants across the U.S. And the interesting finding there was even after about 20 years, no patients were listed for heart transplant despite getting upwards of 600 milligrams per meter squared if they got dexrazoxane. Comparison group from CCSS that was also linked had a few cases of heart transplants over the same period. The numbers are very small, but it certainly is pretty astounding that you can have, close to 300 people get 450 to 600 milligrams per meter squared with dexrazoxane and not have any be on the wait list for a heart transplant or have gotten a heart transplant. So it's not direct evidence, but the lack of a signal there is also, I think, consistent with what we found.
Thanks, doctor. I think we have one last question. The dose of diazi you use in pediatrics, and do you recommend it along with other anthracyclines, mito, and other anthracyclines other than doxo?
Yeah, so the data for other anthracyclines is not as well established. I think the best paradigm is when AAML 1831 was designed. And I think there are at least a couple of papers now published about AAML 1831's design and kind of some initial results. That was using daunorubicin and mitoxantrone. And so there was a discussion, for example, because we found previously that mitoxantrone may be 10 times as cardiotoxic as doxorubicin, whether the dose, instead of being 4 times, which is usually the dose equivalents that we use for mitoxantrone versus doxorubicin in terms of hematologic or myelosuppression, right? There's a question of whether the dexrazoxane should also be dosed at 10 times, but we felt that given familiarity with a lower dose was probably still safer because we didn't want to enhance dexrazoxane's own side effects, which still exist, and they include myelosuppression and some of the side effects that are linked with kind of lower counts. So at least for that trial, we still recommended a 4-to-1 dexrazoxane to mitoxantrone kind of conversion and not use the 10-to-1. And I can't remember what we used for daunorubicin, but from that protocol anyway, there's some at least guidance if one wanted to follow it. And the safety data from that trial should be hopefully published in the next year or two, since the accrual is largely met at this point.
Thank you so much. Looking forward. Thank you so much for joining us, Dr. Eric and Dr. Tim. Thank you everybody for joining. I think we'll wind up for the day. Have a nice day to all of you and have a nice weekend. Thank you.
Yeah, thank you.
Pleasure.
Thanks.